My name is Dr. Halim Jafar. Today I'll continue on my lectures on the influence of systemic condition on periodontium. We described or discussed the endocrine, the hematological effect, the psychological effect, and we reached to the medications. Actually, we have other effects, but I found these four more precise in their effects than the others. For example, we have nutritional effects, we have genetic effects, but I prefer to discuss with you these four terms, or the effect of these four conditions. We have medications, and throughout medications I chose for you the bisphosphonate and corticosteroid. Actually, some medications prescribed to cure, manage, or prevent the disease. These may have an adverse effect on the periodontal tissue, on the wound healing, or the host immune response. Bisphosphonates are a class of widely prescribed medication that have recently associated with osteonecrosis of the jaw, while corticosteroids have long been described or prescribed to suppress the immune system in the control and management of autoimmune disease in cancer treatment, and as an anti-rejection medication in transplant patients. So we are trying to describe briefly these two, the effects of these two drugs. Actually, regarding the bisphosphonate, they are primarily used to treat the cancer and osteoporosis. They act by inhibiting the osteoclastic activity, which lead to less bone resorption, less bone remodeling, and less bone turnover. So it enhances the bone growth and prevent the osteoclastic activity or bone loss. So it acts by minimizing or preventing the bone loss in many cases. So this is good, actually, enhancing the bone regeneration. But sometimes in cases that causes a case of osteonecrosis of the jaw, we have the effect on the oral cavity and the whole body. The effects that happen inside the oral cavity in case of osteonecrosis. I am not going to discuss the osteonecrosis because it's a long subject, but we are here to discuss the effect of this type of a drug on the periodontium. In cases of osteonecrosis, the site that involved may be painful, with surrounding soft tissue induration and inflammation. Infection with the drainage may be present, and radiographically the lesion appear radiolucent with sclerosis of lamina dura and loss of lamina dura or widening of periodontal ligament in areas where the teeth are present. So it will affect the alveolar bone as general, and these effects sometimes be very apparent, happen as a necrosis inside the oral cavity. So this is simply the effect of the adverse effect of bisphosphonate. But not surprisingly, the bone preserving action of bisphosphonate has been studied and advocated for use in the prevention of bone loss from periodontal disease. We have several studies that's shown that bisphosphonate applied topically or administered systemically have the potential to prevent alveolar bone loss caused by periodontitis. The use of bisphosphonate in bone regeneration has been proposed as well, although some studies have demonstrated bone preservation with low doses of bisphosphonate. Higher doses and longer administration may have a neutral or detrimental effect on bone loss caused by periodontitis. So we are here afraid from osteonecrosis, from happening of this condition. Otherwise, it has its effect. It's, let's say, a good effect on the prevention of the alveolar bone loss or the bone loss around the teeth. So we have adverse effect and good effect of bisphosphonate as determined through researches. So this is regarding the bisphosphonate. Regarding the corticosteroid, in humans, systemic administration of cortisone and ACTH appear to have no effect on the incidence or severity of gingival and periodontal disease. However, renal transplant patients receiving immunosuppressive therapy like prednisone or methylprednisone, azathioprine or cyclosporine have significantly less gingival inflammation than control subjects with similar amount of plaque. So, exogenous cortisone may have an adverse effect on bone quality and physiology. In a case control study of a multiple sclerosis sufferers on long-term steroid therapy found no difference in the incidence of periodontal disease between case and control. These are studies. There is controversies between the effect of corticosteroids. And in human, systemic administration of cortisone and adrenocorticotropic hormone ACTH appears to have no effect on the incidence and severity of gingival and periodontal disease as stated by this scientist. However, renal transplant patients who are receiving immunosuppressive suppressive therapy has significantly less gingival inflammation, as we talked about, as Bain et al. Stated that in 1982. And in 1956, injected cortisol, this scientist said that injected cortisol preparation directly into the gingival tissue of 5 patients with periodontal disease shows histologically reduced capillary permeability, fewer plasma cells in granulation tissue, and the inhibition of collagen synthesis and clinical improvement in hemorrhagic hyperplastic gingivitis. While Haim in 1962 observed that topical application of corticosteroid to the inflamed marginal gingiva of patients with periodontal disease resulted in reduction of inflammation and sulcus bleeding with no effect in the progression of periodontitis. While another scientist in 1984 studied the effect of prednisone therapy on gingival inflammation and observed that there was no influence on the severity of periodontal disease. So there is a controversy regarding the use of corticosteroid. Stresses, as we talked about in the previous lecture, increase circulating endogenous cortisol level through stimulation of adrenal glands. That's say hypothalamic pituitary adrenal axis. This increase the exposure to endogenous cortisol may have the adverse effect on the periodontium by diminishing the immune response to periodontal bacteria. So we discussed in detail actually regarding the effect of stress on the periodontium. So this is the effect of corticosteroids. And in conclusion, regarding the effect or the influences of, like for example, hematological influences, stress, medications, and etc., we should know that dentists need to appreciate the wide range of systemic conditions that have periodontal implication to modify the treatment of the affected patient. And in some cases, the dentist may be the first doctor to diagnose systemic disease based on its oral presentation. Recurrent periodontal abscess and accentuated gingival inflammation and periodontal bone loss occur more frequently in diabetic patients. Some cases of leukemia have been first diagnosed in the dental office because of the abnormal pattern of the gingival hyperplasia, necrosis, and bleeding caused by associated thrombocytopenia, which happen in leukemic patients, which result in the unusual sign of internal bleeding and ecchymosis of the gingival tissue. Other diseases associated with the deficient polymorphonuclear leukocyte function, such as Papillon-Lefèvre syndrome, Down syndrome, these are genetic factors. These are mostly present with aggressive form of periodontitis. Hormonal changes of progesterone-estrogen complex can accentuate plug-induced gingivitis. This is most profound when it occurs in pregnancy, but cyclic menstrual change, puberty, and the use of hormonal-based contraceptive can make gingivitis more severe. Also, nutritional deficiencies need to be severe and prolonged before any dramatic periodontal manifestation will occur. In severe form of malnutrition, periodontal deficiency, or the periodontal manifestation will observed. Well, like for example, vitamin C deficiency, as we know. While in osteoporosis, doesn't have a dramatic periodontal implication, but edentulous alveolar process may be more affected than alveolar bone supporting the teeth. Recent widespread utilization of bisphosphonate therapy has focused attention on bisphosphonate-induced osteonecrosis of the jaw, which can occur spontaneously or follow surgical procedure such as tooth extraction, periodontal surgery, or implant surgery. The risk for this particularly high in patients subjected to intravenous administration, and these patients need to be managed by dental specialists. Oral bisphosphonates carry a lower risk of osteonecrosis sequelae, but even these patients may be better treated by non-surgical therapy. So this is the conclusion of the effects of this subject that we talked about, the effect of systemic condition on periodontal diseases or on the periodontium. So this is my lecture for today. I hope you get benefit from it, and in the other lectures we may talk about the effects of periodontium on the systemic conditions. Here we have effect or influence of systemic condition on periodontium, but also we have an effect of a periodontium on systemic condition, because it is a two-way effect. Both of them will affect each another. Thank you for your listening, and have a nice day.